This case study will tell the story of the Greensboro Health Disparities Collaborative. The objectives of this module are to identify systemic healthcare factors that influence health outcomes, to describe how racism is a determinant of health in the healthcare context, and to describe strategies used to develop solutions to problems faced. To begin to explain the story of the Greensboro Health Disparities Collaborative, you must know a little bit about Greensboro. Greensboro is considered to be an urban city in North Carolina consisting of approximately 275,000 residents. Greensboro was the site of a significant success during the Civil Rights Movement and the struggle for equality. Greensboro is a city where the sit-in movement began in 1960. The purpose of this movement was to racially integrate restaurants across America, starting with the lunch counter at the Woolworth store in downtown Greensboro. Greensboro was also the city where Black physicians sued a local hospital to gain access to practice medicine in the formerly all-white hospital. That legal case, called Simpkins v. Moses Cone, was won by the Black physicians in 1963, and it has set the precedent to racially integrate all hospitals across America. Although African Americans were granted access to medical systems in Greensboro, unfortunately, racial health disparities still persist today. For instance, nationally, cancer is the leading cause of death among all races. However, while there are higher rates of white women who are diagnosed with breast cancer, there are higher rates of Black women who die of breast cancer. This statistic and other research studies indicate that Black women experience problems after having access to medical care. These problems surface while matriculating through the medical system. This is an example of institutional racism. These are some of the problems that the collaborative faced.
In about 2002, the executive director, who was a Black woman who had been a lifetime community organizer and an active force in the partnership project and in her community, she had an experience in the hospital system in Greensboro that was very disturbing to her and that she felt was clearly related to issues of institutional racism. That same year, 2002, the Institute of Medicine published a meta-analysis that had been commissioned by Congress on health disparities in the United States. The analysis was published as a very thick book called Unequal Treatment.
Well, I came into the collaborative in 2003, and at that time, although I wasn't aware of all of the backstory, that one of the members had lost her husband to cancer, and there was some concern as to whether or not he received quality care for his condition. There are at least 3 members of the collaborative who were breast cancer survivors, so there was a lot of concern about disparities.
It was around the time that the Institute of Medicine report came out on unequal treatment, and that concerned a lot of community members who really had experienced difficult treatment episodes within their health care in the past, but now a report came out that really formalized that this problem really existed and that we needed to be proactive in solving it.
And when they analyzed this meta-analysis and they controlled for all of the factors that we traditionally blame health disparities on, when they controlled for income, when they controlled for neighborhood, when they controlled for comorbid illnesses, when they controlled for what type of health insurance people had, they found that Black people had worse outcomes in every disease that they looked at across the spectrum. So that the health disparities existed after controlling for all those factors that we blame health disparities on.
So these disparities are here based off this medical report, but how are they there? What happened, and does racism have a part and to play in that, and how do we show that?
Why and how racism existed was big for me.
And so for the partnership project, they felt validated. They knew all for generations that this was happening in the healthcare system. And so for them, the question was no longer, is there unequal treatment in healthcare among people, for people of color, but why? They really now wanted to know why was this happening, and then what should we do about it?
Why was it that people of color were not having as good of outcomes as white people or white patients when they go through the healthcare setting? What created the differences?